I think we are good to go. If you are a founder who has never been ghosted after hearing flowery compliments, you are probably as rare as a unicorn. Most founders crave the real stuff, brutal honesty, and tough questions, but unfortunately, they receive empty praises or vague promises. Because who wants to burn bridges with the future billionaires? The truth is, constructive criticism doesn't break founders, it sharpens them. It is what helps them learn, improve, and ultimately thrive. That's where EthAum comes in. Our roast sessions are designed to turn up the heat, live and unfiltered. Founders face tough questions, real feedback, and zero fluff from seasoned experts. Think of it like Shark Tank, but less drama and more insights. Today we have Erez, founder of PathKeeper, stepping into the spotlight. He is here to share his solution, answer some tough questions, and get real feedback from our very diverse and awesome panel. I would now request our esteemed panelists to introduce themselves and probably give a brief intro about their work. If I may start with Jordan. Jordan, please.
Well, good morning to everybody. I'm Jordan Wahbeh with Silicon Valley Venture Group. I'm also with Network VC. I'm calling from California. When Pankaj calls, we say, we're right there with you, brother. So if he ever calls you, you're an investor, you better answer the call. We invest in pre-A and Series A companies, deep tech, enterprise class services and products. We deploy capital 2 or 3 times per quarter. We follow, we don't lead. I've been in this business since 2015 with corporate background, software, hardware, and a wide range of things. One of my best friends in the Valley calls me, I'm the mean VC because I give it up straight. So, but I know Erez, so I'm going to be more loving and kind to him than I usually are. Good to see you again, Erez.
Thank you. Thanks a lot, Jordan. Appreciate your time. Okay, may I request Soumitra to go next, please?
Hey, thanks, Pankaj, for this invite, and nice to see PathKeeper and Erez. So I'm Soumitra. I happen to be the lead partner health tech for Crystal Ventures Studio and Claris Capital. So we are a thematic fund based out of India, early stage investments, and we are into health tech for that matter, folks that are into AI and building digital infrastructure. So that's about me. And by background, I am a healthcare professional with about 17 years of experience. Started with strategy consulting, then moved into as an angel investor, then into VC. So it has been a journey for me. And nice to be a part of the panel and hear Eric.
Thank you.
Thanks.
Thanks a lot, Soumitra. Appreciate your time. May I request Danielle to go next, please?
Sure. Good morning, everyone. It's a pleasure to be here. Danielle Tarraf. I'm the founder at Tech Horizon Ventures. I'm also a venture partner at NextGen Venture Partners. I come at this having been on different sides of the divide. I've been a venture investor at different points in my career, but I've also been a builder, an entrepreneur, and I've been a strategy and operations leader and an advisor to strategy and operations leaders at various firms, including at McKinsey and the Rand Corporation. Pleasure to be here. I've worked across multiple industries, obviously health tech, but also I've worked in energy, I've worked in defense, and I've worked in tech and the AI value chain more broadly. And I'm excited to be hearing the pitch today.
Thank you. Thanks a lot, Daniel. Appreciate your time today. May I request Dr. Ali to go next, please?
Hi, I'm Dr. Ali Shirazi. I have a PhD in industrial management, and I've been working in industry for the last 17, 18 years. So I work in different sectors like medical devices, healthcare, aviation, consulting like Deloitte, Johnson & Johnson, IKEA. Now I'm working as a head of Smart Factory AI and Digital in Sanofi.
Fantastic. Thanks a lot, Dr. Ali. Really appreciate your time. Last but not the least, may I request Ayman to go next, please?
Yeah, thank you very much, and hi, everybody. My name is Ayman Ababneh. I'm handling the global expansion for a company called Open Medical, which is focusing on digital healthcare part. My experience spanned from medical equipment surgical equipment and consumables and digital for more than 17 years. And my background is actually biomedical engineering, and I completed my PhD in strategic management and innovation. So happy to be here and to see and know about these fantastic solutions. Thank you.
Thanks a lot, Ayman. And again, thanks to all the fantastic panelists today. Again, feel free to be honest, direct, and turn up the heat a bit. Erez is ready with answers and a metaphorical ice bucket. Let's have some fun with the session today. Now, I would request Erez, founder and CEO of PathKeeper, to introduce himself and go through the presentation. Erez, please.
Appreciate that, Pankaj. Thank you, Pankaj, for arranging the event today, and thank you, panelists, for joining. And very interesting and diverse, and I'm honored to have you spend the time listening to me and questioning me and helping me be better. I mean, that's what I hope will be the result. So I'm an engineer in my background. I'm Israeli. I am engineer in my background, electrical engineer in mathematics. Spent my first 10 years in the Israeli aerospace industry in the satellites, mostly about safety and data analysis around satellite launches. So our Israeli mini NASA that operates here from little Israel. And for the last 15 years, I've been working in the medical device industry. I was the head of R&D and product for the Invisalign 3D imaging, for dental 3D imaging, and developed the iTero element, which is today still #1 3D imaging solution for dentistry. And about 7, 8 years ago, I met a professor that just came back from HSS in New York. And we decided to start PathKeeper together because we felt there is a significant need and significant problems that we believe that 3D imaging and AI can solve. So since then, PathKeeper has gotten FDA clearance and have done more than 150 surgeries and also signed a few big commercial agreements, one of them with Vizient, which is the biggest GPO in the United States, and the other one with High Ridge Medical, who is used to be the spine division for Zimmer Biomet. And let me tell you what are we solving at the moment and what's our plan. So if you're looking at spine specifically, that's where we decided to start. The anatomy is very delicate. If you look at, for example, a cervical procedure here, the surgeons doesn't see much. But to create a fusion or to stabilize the spine, they have to put screws in a very tight spot. In the cervical, if you miss a bit to one side, you hit the nerve cord and create paralysis. If you miss too much to the other side, you might hit the aorta or just have somebody was working here with IKEA. It will be like an IKEA furniture where the screw is off and something breaks. And the statistics, the research shows that about 30% of the screws are misplaced, some of them in a very significant clinical way. And technology is here to help, like in many other places where there's an acute need. But technology today is based on X-ray radiation. Buying an extra, usually 3D CT machine for surgery room that takes a lot of X-rays during the surgery and help the surgeons do better. But that comes at a cost, financial cost, time cost, but also radiation risk cost, both for the patient and surgeon. It also comes from a trust cost because using this technology, you cannot be continuously taking X-ray scans during the surgery room, at least not 3D scans, which means that if something changes or moved during the surgery, and we have clinical proof that things move, your system will not be accurate. And surgeons knows that, and that hurts the trust situation for using technology in a very complicated and high-risk scenario. So our technology is based on 3D imaging, which is my core expertise, and that eliminates the radiation in the surgery room. It also uses AI to really track the anatomy of the patients. And the new design allows us to be compact, affordable. So thinking about third world countries, but also thinking about the new emerging market in the United States for private hospitals, ambulatory surgery centers. But it also such a generic solution, the AI and the imaging and the platform, that we can really think beyond spine. So it's not just a spine solution. We are already working on knees, and we can see how we can expand more and more beyond orthopedics and even beyond neurosurgery. The core technology are our 3D imaging, which again, that's where I come from. And our system is 10 times better than our only competitors out there. The second important aspect in our technology is the ability to work with any type of implant tools and surgical tools. For surgeons, tools are critical. They are the extensions of their hand that do the operation. So it was very important for us to allow surgeons to customize their tools, to use any type of tools they want in any type of procedure that they want to work with. And the back end is the anatomical AI. Every surgery that we do, we collect data, we improve the AI, and allow us to create a very, very high accuracy system that really understand what happened and start building more and more capabilities around that. Because if we are AI heavy, the design can be simple. So it's low cost, it's portable, and really suitable for the healthcare economics, not just for the clinicians. Just to give a bit of a taste about what AI can do in spinal surgery, I chose three little items that are easy to understand. The first two here are about safety. If the surgeons get it a bit wrong, and he or she is a bit out of the way and going to hit the cortical bone, we are going to alert them. If the surgeon is working on the wrong level, we are going to alert them. And wrong level surgery is a huge risk. It doesn't happen a lot, but if it does, it can ruin careers and cost millions of dollars in severance pays due to legal litigation. But more than that, we are able to start for the first time measure corrections and position changes during the surgery. So surgeon can start become like an engineer. If you work in your home and you have a builder coming, you ask them to measure before they start cutting and building. Surgeons today are unable to really measure. They have to use their experience to make decisions. We want surgeons to measure. And then it will improve directly the clinical results, I'm confident, but it will allow us to start building more and more capabilities on top of that. So as I said, we are now in the spine. We have a big, important commercial agreement with Hydro Medical, but we want to keep extending. We are bringing a new, first of its kind, miniature 3D camera for 3D imaging in spine for MIS surgery, anterior surgeries, and others. And we have started doing a proof of concept for markerless knees. Knee surgery is one of the most common orthopedic surgery, very common in ambulatory surgery centers, but requires significant clinical risk to put pins in the tibia and femur for the robot system. We can be the first company in the market to be markerless TKA, and that really is a game changer. And we'll continue to evolve and grow our market opportunity during the years. So where we are today. So as I said, signing a deal with Hydro Medical, a $500 million company, one of the top 5 spinal companies in the United States. They've already purchased 12 units and they're starting to install them and build the funnel. Their expectations, here's where I will not say numbers, the expectations are very high for next year. In parallel, we are working with some big groups. And we are working with KOLs like Mayo and Hadassah in Israel, but we are also working with Vizient and USPI, building their relationship and creating access to large networks of hospitals with hundreds and sometimes thousands of sites that once approved will give us a very significant commercial access. So building the infrastructure. So we have an agreement for $2 million for 2025, and our conservative goals for next year is to reach $5 million in revenues. Our revenue drivers come from capital sales and recurrent revenue. And we are capable of doing leases where it's required. But basically, conceptually, it's important to think that there is a capital equipment and there is a consumable equipment. And we have an 80 to 90% gross margin, which allows us to be flexible in the pricing and the sales model. And once we get to knee and cranial and grow, we will have a very, very significant, it's already $1 billion, multi-billion dollar market, but it's going to expand more and more after that. So when there is acute need, there are multiple companies competing, and this is not different. But as you see, most of the big companies like Medtronic and Brainlab are still using legacy technology. We're talking about big X-ray machines going into the surgery room and taking scans, spending 10, 15 minutes every time they have a scan. I just yesterday talked to a pediatric surgeon from Israel. They're doing 3, 4 O-arm spins in a surgery. When everything goes well, each spin is about 15 minutes. So spending an hour just radiating your young teenage person instead of taking care of them. There's only one competitor now that is optical, like us, 7D Surgical. 7D Surgical was bought by by a big American company called Orthofix. But we have proven again and again that our technology is superior to them in several aspects, which we can talk about later. So I'm very proud of our team. Our US team is comprised of our chairman, Dr. Westmark, who is a neurosurgeon and a very experienced businessman in the United States, very well connected, and Ryan LeBlanc, who is our chief commercial officer, who has been doing spine sales for many years and has a vast network of distributors and surgeons that trust him and know him. Our clinical advisor and one of our founders, Professor Schroeder from Israel, HSS fellow, well known in Israel and in the United States. And our technical team from Israel, led by Dr. Ofer Kinrot, very strong clinically with great experience in AI and imaging. So we're doing a $10 million round now. Our goal is to really beef up and grow the commercial team in the United States so we can work with high-reach and work alone. And I think it's a great opportunity for investor because we are already there. We are already clinically proven. We already proven the product market fit with the high-reach and the Vizient deals. We have a strong team, and we are really at the tip point for growth. And we need partners to help us take this opportunity and make it into a real growth company. So thank you for the time, and be happy to answer your questions now.
Fantastic. Thanks a lot, Erez. I think you were very quick with your presentation, so that's good. We have a lot of time for questions now. Okay, panelists, please feel free to unmute yourself and yeah, go ahead, Dr. Ali.
Maybe I can start. I have a few questions. I think it was a very interesting one. I must say that you have done a very fantastic job. But something which I might miss, maybe it's not very explicit in your presentation. Which kind of model you use to create those algorithms that's okay. You have when you're doing the surgery, this is less level, this is more level. Which kind of model you use, and what kind of a data you have, which kind of representation? It's a data from a certain area, from a certain country, because I think that's when you go into the bigger market, then you need a big representation of data if you move from North America to the South America, because I think that with every surgery, the data is different for each person. So I think in healthcare, it's very difficult to standardize and customize things based on the available data because each patient is different from the other one.
Yeah, it's a great question. So we have two types of data sets in our system. The first one is the CT data set. The data set that how does the spine look like based on high quality CT. We have collected the data sets of several thousand cases. Each case has usually several vertebrae. So there's a lot of data there. If you look per picture, we're talking about more than 1 million pictures, very varied data sets for healthy, sick patients. We're doing pediatrics, so a lot of kids, a lot of sick people, but also normal people. So we have created a very large data set that we start with. And like every type of AI system, you're never sure you're 100% correct. So each time the AI makes the analysis on the DICOM, there is a human to verify that it's fine. We see that in 90% of the cases, the human doesn't need to do anything, but there's always a situation where there's need some sort of human corrections on the AI part. The second part is the real surgical data. And there where a 3D camera takes anatomical data from the patient and match that to the AI. This is done semi-automatically, and the surgeon is there to support. So the surgeon usually tells us where is a clean bone to start the match operation. And once it's done, the surgeon is verifying. So the surgeon touches the anatomy and makes sure that it's accurate. If the system got it wrong, the surgeons will be alerted and can take an extra measurements to help the system get a fix. So it's always human verified. Our goal is to get closer to 100% success. But you're right, humans are complex, and especially people that need spine surgery have non-normal spine. That's why they're going to spine surgery. So we are always keeping the option that the AI got something wrong and the humans need to rectify.
And maybe just one more question. Is your devices FDA approved, because now they have new regulation for the softwares, which comes under, and also AI comes under that as well? Is it, are you
Yes.
going to do?
Yeah, so the system is FDA approved. The way we handle AI, because it's a high critical system, is not to do continuous AI improvement. So, I mean, like ChatGPT, right? Every couple of months, they have a new version. So that's how we do. We collect all the data, we run it through our database until we can prove that the algorithm is better in some way versus the previous algorithm. Then we report the data to the FDA and bring the new algorithm into the market, start with some alpha testing and careful under clinical trials in Israel, and then bring it out into the general market in the United States.
So I have a couple of questions that actually piggyback on the questions that were asked. Sort of as an engineer, I started my career as an engineer like you, Erez. I get a little bit suspicious, when people tell me, hey, it's hardware agnostic, we can use it here, we can use it there, we can use it on cervical, we can use it on this and that. In theory, yes, but practically, how much effort do you need for every new application in order to get to the point where you can get the accuracy that you need, especially when I see the development timeline where you're showing year after year, you're moving from one, from cervical to knee to whatever.
Right.
And the other aspect is the FDA approval, which is that a process you need to restart every time you go to a different application? So if you go to the knee or something else, are you starting from scratch, or is it really you're piggybacking on what you've done?
Okay, so great question. So let me explain what I mean with hardware agnostic, and maybe it was not clear enough. So I'm not talking about anatomical agnostic. What I'm talking about is just the surgical tools. So the surgeon can choose their own screwdriver, their own probes, their own tools to use in the system. And what we have a calibration process that you show the tool to the 3D camera. The 3D camera learns the new tool, and then we can support it. Now, there are rules. Of course, we cannot support if the tool is made of rubber and can change its shape during the surgery, I cannot support it. But any tool that is stiff, I can learn its shape and support. So that's what I mean hardware agnostic. Any normal or standard tools in spinal surgery and can support. And yes, you're completely right that moving from spine to knees needs to do something different. Now, the beauty here is that the difference is not in the core technology. It's not in the imaging, it's not in the AI, but it's in the workflow and the surgical tools. So doing the way a surgeon decides how to cut a knee for doing TKA is different than how the surgeon decides how to cut a spine for spine surgery, and different than how the surgeon will decide how to cut a hip to do a hip surgery. So the workflow is different. So we have to do different workflow, different UX, and maybe develop different surgical tools, how to cut and how to guide the system. But the core technology is the same. So when we do, so for example, for me to do a proof of concept, you know that you as an engineer will understand that it works. On knees, it's nothing. I just went into the surgery, took pictures, put it on Python, and I can prove to the surgeon that it's accurate. But to make that something I can sell, now I need to invest in tools, I need to invest in workflows, and I will have to do an additional FDA application. But yes, it's piggybacking on what we have done. We have an ISO 13000, we have background with the FDA. We have proven to the FDA that we are very, very accurate, that our technology is accurate, that we are safe. And every time we add something, we go to the FDA and we show him the data that we have collected since then. And we also know what is the level of accuracy, the level of data that the FDA requires. So, first time you go to the FDA, you're almost shooting blind. I think my data is fine. What do you guys think? So we are past that. We know what the FDA expect. We know what we need to be. And we've proven that we are, at least in spine, 5 times more accurate than the FDA threshold. So we know how to handle them, and that's why it's streamlined. Yes, it's work, but it's streamlined and relatively low risk from technology-wise. Still need to work, still need to do stuff, but technology, low risk.
Hey,
It's because we have extra time. That doesn't mean you give us a 90-second answer for a 3-second question. That was a very,
I was
very.
waiting for that feedback from
That was
Jordan.
just way too long, brother. And from there, you gave me a lot of ammunition to shoot right back at you. I'm going to give it back to Danielle because the questions were not quite answered yet. Go back to you, Danielle.
No, it's for you. I thought it was an interesting comment you made, so go ahead.
So Danielle's point is valid. As an investor, if you're going to go to FDA every step of the way, what's the level of comfort you think I would have as an investor that you're going to get the approvals, as well as the capital and the resources you're going to invest in going from step to step to step? Also, at what point in this very long journey are you going to go for an exit and give us our money back? Because that's a lot of work for the next 5 years, and I'm not seeing substantial revenue growth over that journey. What do you think, Danielle? Do you see the same thing, or is it just me?
No, I agree with you. So I'd love to hear that. That's kind of what I was getting at.
Okay, so try to make it short, Jordan. So FDA hurdle, very low. Very low cost, very low, and I'll explain why. We have the paperwork. We have the clinical data. We know exactly what the FDA needs. Doing a cadaver lab costs $10,000. Doing the paperwork, because we have ISO and we have everything, one guy doing the work. So potentially, I can do 2 cadaver labs and have the data for the FDA plus a bit of clinical trials, which we do anyway. So I can do FDA submission every 3 months and get it 3 months after, because I know exactly what I'm doing and I've done it before. And even in our first FDA application, the cost was not high, and we had some feedback, but we got FDA in 6 months for our first application. For our second FDA application, we showed them what we want to do. They said yes, we applied. So FDA, 0 risk.
So I'm looking at your revenue for the next 3 years, which is about $17 million for the next 3 years,
Right.
mapped on top of an FDA journey that's going to cover 5, 6, 1, 2, 3, 4, let's say three utilities. Are these 17 million just for the spine, or do they include the knee and the joints, or what's clarify it for me, please?
Yeah, these are conservative estimates. They are for the spine. My estimation that we'll start selling knees in 27. I'm still looking for a good commercial partner like Highridge for knees, and then numbers can propel and become much, much higher. But since we are a low-cost company, we could be cash flow positive in 27 if we want to, and definitely beyond that. So the investment level that you as an investor needs to help us go through the process is relatively low. You don't need to invest a lot of money.
I'm not convinced.
Yeah, we can go into the financials.
Let's turn it to someone else, and we'll come back to that in a minute.
Yeah.
Other people ask questions.
Thank you very much. I may I have a quick questions, not to make it long, but relevant to the asking about sustainable value proposition here. So looking to the competition landscape and current competitors who already have a huge installation base like Medtronic and also the companies who are working on intra operation imaging technology, and even the company working on just software, navigation software, planning tool there. So my question is, if these trends and companies who are already spending heavily on R&D on this aspect, if getting cheaper and lower dose, so where's your advantage in 5-7 years from now? That's a question, especially that why wouldn't a hospital just keep current robotic navigation system and buy cheap AI planning tool instead of buying a hardware and your software, and especially that orthopedic field is under pressure dealing with GPO, as you mentioned in US there. So that's the first question related to, is it sustainable looking to this, what's going on in the competition field there? And similar to that is looking to the surgery center, the segmentation of the market itself. If you can have more elaboration on that, because I do believe that surgery center, they have C-arm today, and it's hard financial logic to them to spend more than $300K on disposables to bring that, especially the incidences, for example, in UK, less than 1%, the misplacement in the spine. And sometimes it's clinically not that impact. So that's a question about your segmentation, how you see the segmentation and can be targeted to very specific segment there. That's also relevant to the forecast that you are putting. Is the forecast considering such segmentation there? So that's the questions, and thank you very much for the presentation.
Thank you, Ayman. Let me try to I hope I remember all your questions. I'll try to answer them one by one. So regarding current installations, so yeah, Medtronic is very strong and other companies are very strong. But there's two places where we see the potential is very big and very considerable. The first one is the ambulatory surgery center. As you said, there's very, very few surgeons who do ambulatory surgery in spine today because they cannot buy $1 million robotic system from Medtronic. So for us, bringing a low cost, even a leasing model for ambulatory surgery centers, this is almost a blue ocean opportunity. Just USPI, which I mentioned before, 500 hospitals that don't have anything, and we can go there. The second one is pediatrics or complex spine, where movement is critical, where radiation is very big problem. Can you imagine a parent sending their teenage daughter to get 1,000 X-rays if they can send their teenage daughter in the abdomen? Instead, they can send it to a radiation-free navigation solution. So I think everybody is expecting optics to take over in the future. So that's the first one. Second, can I sustain my compatibility or advantage? So I'll give you, you never know the future, but everybody has to have navigation. So planning does not replace navigation. You have to have something real time. So I can give 3 examples that hopefully will convince you that 3D imaging is not something that becomes cheaper and easier, but nobody knows the future. The first one is what I mentioned about Invisalign and the iTero. I left Invisalign 10 years ago. They're still selling my hardware. So there was no significant change in the hardware since I left. Everybody copied my technology, but it's still number one company I left 8 years ago. Second, when I started building PathKeeper, I've talked to the Medtronic team, and they were working on 3D imaging back then, 2018, before I raised my first dollar. They still don't have a 3D imaging. I met another big strategic company, which I will not mention, and that relates to Jordan answered. We were negotiating about an M&A with them, and they admitted that they tried to develop a 3D imaging and optical solution like ours for several years, spent millions of dollars and got nothing. So they were willing to do an M&A with us, and this is still in discussion. So I believe developing real 3D imaging for healthcare is very difficult, and it will continue to be difficult. It will require certain expertise. Combine that with the AI, the fact that we collect data per surgery and improve the system per surgery, which is a new concept that our competitors does not have, means that our moats are becoming bigger and bigger. And that goes back to Jordan, where you want to ask about exit. Creating this big moat, creating this significant advantage when the micro camera comes to the market, our moat and our advantage become so high that people are already talking to us about an M&A. So it's becoming almost our decision. Do we want to sell quickly, or do we want to create a billion-dollar company? And at the moment, it is our decision. The discussions are going both directions. I'm not going to say where it will end, but options are there even for an exit, Jordan, or to build a big company.
Let's take more questions.
Yeah. So, I think it was a fantastic presentation and definitely noble in a noble venture. But I'm also a little concerned about the growth of revenues, but you have some answers to it. How you're going to make the AI and the technology even better so that, it's better than what is there, and you have barriers to entry. That's one. But one fundamental question I have, so you mentioned about, obviously, you're not exposing the patients to radiation, patients and doctors to radiation, especially when it comes to pediatrics and all. That's well taken. But how do you quantify your value proposition in terms of, let's say, the cost takeout, for that matter?
Right. So the simplest way, there's few ways to do, value. One way is to say, for pediatric surgeon, I'm saving 45 minutes per surgery. It's usually counted as about $60 per minute in a surgery room. You can do that. You can do a more elaborate way and say, okay, if I'm removing the cancer risk for kids because of taking 5-OARM grows for 5%. That's a huge financial burden. But the third one is for the ambulatory surgery center. And here it's an enabling technology. If you're a surgeon and you have two options, you can do a surgery in the hospital and get $5,000, or you can take it to your private hospital and get $35,000. Then the value of my system is $30,000 per system, because for you as the user, you'll make $30,000 more per surgery by just moving your case. It's your patients, it's your case, you're just taking it to your private facility. And that's the real value. That's where the real money comes from. Moving the stuff to the ASC. Everybody wants to do that from that reason, and we will bring the force back to the surgeon hand to make the decisions that are best for his patient, but also good for his economics. And that's the
Absolutely.
huge shift.
A couple of things here. One is basically the economics for the doctor. The other is economics for the healthcare system, as you see. For example, it's about radiation, less exposure and all that kind of stuff. But at the same time, what's happening is there is what you would say, readmission rates could decrease, the emergency room visits could decrease. So also helps in that way to drive down the cost. I just wanted to bounce this thought, if you would have thought of it or not. The second is I understood the barriers to entry that you're creating. I think probably you answered it when you talked about competition and how you are doing when you're having a trade-off between the revenues, the way you want to grow and way you want to build the best of technology that is there so that, the technology keeps on, what I would say, evolving. But one more question I have is like, let's say you are guiding the doctors to navigate the, spine when they're doing the surgery and, they have these things. But how about, it's a combination of AI and human, the human skills and the AI that comes into picture to give the optimal results. But are you contemplating of a system where, the robotic surgery gets one level higher or the level of autonomy, or it becomes from, one step to semi-autonomous to autonomous and all that kind of things. Where are you on that and where do you see yourself moving towards?
Yeah, so at the moment, robotic sales are plummeting because of healthcare economics. I think you're right that in the future, robotics will come back to surgery, leaner, better, more autonomous. But for robotics to be autonomous, which they're completely not today, they need good eyes. And that's my expertise, good eyes. So I can keep my eyes for myself. I can merge with a robotics company and be their eyes. I can bring the robot myself and make a robot with eyes. But every type of robotics that progresses beyond what they is today needs good eyes and the ability to analyze what they're seeing. And that's my expertise. That's what I'm doing better than anybody else. So it's just good for me.
I think that's all. Only the last question I have is obviously you have a lot of data and a lot of insights through your, through the ASCs with whom you have worked. So when you're moving from ASCs to the next segment of hospital, let's say larger health systems and all, what's the, the magnitude of change that's needed and how does it pan out?
Right. So we designed the system for the change for the surgeons will be minimal. So it will be really, really low hanging fruit or, easy learning curve. But we are starting to bring more AI capabilities that reduce risk for surgeons. And I think that's going to be critical. Reducing risk and adding data that surgeons does not have today, the ability to record surgery, to share surgery, create and open new boundaries that are simply does not exist today. And we will have to see how they are adopted, how quickly. Sometimes things takes long time. That's why it was important for us to bring an MVP to the market and build on top of that and not wait for something that has too many changes. So that's what we're doing.
Okay, Erez. I had those questions.
Thank you.
Thanks.
Thanks a
Thank
lot,
you.
Soumitra. I see Jordan has unmuted himself. Jordan, do you have any questions? Or Daniel?
I certainly do. Just a tip, Erez, it would have been terrific if you put the ROI to your customers. You described it in nice, fine details. A simple ROI, 5x, 6x over the span of something, that would be great. I didn't see any licensing potential for your revenue. You're selling, you're doing SaaS, and you're doing training. Is that the extent of your revenue model?
So we can exchange that with leasing, if that's what you mean, but licensing our
No,
technology
licensing
others?
to third parties where they can take your technology and deploy it on your behalf.
Yeah, so I'm doing distribution model. That's how we work with HighReach. They buy the system and sell it to their customers. So we do that. But licensing of technology, I might do in the end to finance development in other aspects, but I don't see that. I see that as a replacement. It's like grants from my thinking, because it's like one time or small number that helps me propel the system, grow faster without getting a lot of investment, and not a sustainable revenue model.
If I were Kevin Harrington, I would say, you don't like money. The notion of limiting your growth to no licensing is really puzzling, because you could expand into markets 5, 6, 7 times faster without you having to spend money on hardware and so forth. So rationalize that for me one more time, please.
Yeah, I'm definitely happy to learn, Jordan, and talk deeper into the licensing model. As I said, there's distribution model, and like what I'm doing with HighRidge now. HighRidge buy PathKeeper and sell it in the United States, and I have full intention of doing that in other places. Me and Pankaj were talking about India. There's a huge market opportunity. So reseller distribution models, I'm perfectly
No, not that. No, totally not that. Just inserting
technology
yourself.
licensing.
Yeah. Now, before I turn over to others, you're collecting a ton of data in your. Hopefully, you're going to be collecting a significant amount of data. Other than training, what can you do with that information, and how can you monetize it?
Right. So training and safety, they are important. I'm using that to my learning to improve the AI.
Sure.
And one of the big things that I expect we'll be able to do is predictive analytics. So one of the big problems in spine today, something called back syndrome. So there's a situation where after surgery, you're still suffering from pain. So there are situations where surgeons doesn't know if to do a surgery or not, or know what type of surgeries to do. If we can start building predictive analytics from our data, from what the surgeon is doing to the outcome, and start giving guidance of what the surgeon should do, start helping the surgeon plan in a smart way, not in just the graphics, but really predict what's going to happen and come back to the surgeon and say, if you do this and that, this is the probability of what's going to happen, then we'll bring another layer of value to our customers, to our surgeons, and of course, to our patients. So definitely creating a stream of data. Who is the patient going into the surgery? What exactly the surgeon did during surgery? And then what was the recovery profile? That will allow me in the future to go back and help design surgeries to be better.
Thank you, Erez. Let's take probably one last set of questions from Daniel, and then we'll take the key takeaway and final comments. Daniel, please.
Yeah, I mean, let me take a step back here. On the one side, I need to be convinced that there is a burning problem that you're solving. And on the other side, I need to see that the person who has the problem, the person who has the responsibility for solving the problem, and the person who holds the checkbook to sign off on the solution to the problem, ideally would be one and the same. If it's not the case, and I think it's not the case here, the question is, what can you do in the GTM? So I'm willing to accept sort of, yeah, there's a burning problem, you have a solution to it. I'm still questioning this side of the equation. You kind of alluded to the idea that, hey, if I can get the doctor to buy something for their private clinic, effectively what you're doing is the person who has the problem, the person who's solving the problem, and the person who holds the budget for the problem are becoming one and the same.
Exactly.
But I don't see that in your go-to-market. It sounds to me like you're talking to these big groups where actually it goes back to the question where you have 3 different individuals. And if you are focusing on these private clinics, is the market the size that you claim it to be, the multi-billion-dollar market, or is that now a smaller market? So this side of the equation is still unclear to me.
Okay, I'll try to, as you're right, there are a couple of segments, and each segments required slightly different approach, and maybe slightly different timing and slightly different ways how to handle them, and slightly different decision makers that are leading the process. And the easiest one, simplest to explain, is the ambulatory surgery market, where the surgeon is usually part owner, and where if the surgeon is able to do more complex spine in the surgery center, they immediately get more revenue to their pocket. So the surgeon is the user, is the decision maker, is the checkbook, and they need that because they don't have a solution. So you might say, from a very business, cold perspective, the problem is the surgeon facing a problem. He can do a spinal surgery in the hospital and get $3,500 per case. All the rest go to the hospital system and spread around, like hospitals waste their money. or he can have his own private hospital where he's doing simple stuff like decompressions and epidurals and bring a TLIF. And the TLIF pays between $35,000 to $70,000 per case. And that goes directly to his and his partner's pocket. So in a very cold business-like way, that's a problem we solve. Having the surgeon make $35,000 per case instead of $3,500 per case. Very simple cold problem, very simple solution. If you look at it from the complex spine for pediatric hospital and so on, here it's become a more complex sales process. You're right, because now the problem is there's a couple of problems or several problems that we are solving. The first one is radiation. And we eliminate radiation from the surgery room. That's important for the patient, mostly for pediatrics. So you're asking me, how do I monetize patients wanting to do surgery with us? And, the way to do it is to do marketing and telling, if Daniel, you're the hospital owner, and I am an hospital owner, and you say, come to me, I have radiation-free scoliosis surgery, and I say, come to me, I have 5 O-arm spins per surgery. If Jordan is the parent, I believe in most cases he will go to you and not to me. So that's how you bring more patients to you. And I guess it's a complex way. And there's other layers around that. Dr. Soumitra mentioned cost. You will also finish your surgery. Your surgeon will finish the surgery an hour before me. So maybe you can do another surgery a day or something else in that surgery room and make more money, or send your nurses to do other stuff or so on. So you save money by using PathKeeper.
And
So
it
you
is,
save money.
that's a very important aspect in the US healthcare system. You touched upon all the segments. One is the doctors or the surgeons making money for themselves. Second is the type of specialty like pediatrics and all. But the third thing is the US healthcare system itself. And now it's being, there's a lot of mechanisms to contain the cost, like value-based reimbursements and all, where the savings in cost and all the attributes that flow into it assume a lot of significance. And that was the point in me suggesting that.
Right. And I have another one. Give me 2 minutes, Pankaj. There's another layer of solving the problem, Daniel, and I'm sorry, Jordan, for making complex, because you talked about High Ridge. High Ridge is selling implants for $500 million a year. Medtronic is selling implants for $3 billion a year, just in the United States. If you look at the screws by High Ridge and you look at the screws by Medtronic and you look at the screws sold by a small implant company that does $10 million a year, they will look the same. So if you are the CEO of High Ridge Medical or some other company and you want to grow, you need to be special. You want to create your own competitive advantage. The way for High Ridge Medical to have a competitive advantage is to work with PathKeeper. And that's true for every implant company. So for the High Ridge Medical, for Rebecca Whitney, that's what she needs from me, a competitive advantage versus the other implant companies.
That's a very fantastic final statement from your side, Erez. Really, really appreciate that. See, you are sitting in front of experts, right? And it'll be pretty unfortunate if you are not able to ask 1 or 2 questions to the experts, or probably take some guidance, take some insights from them. So please feel free to ask 1 or 2 questions to the experts and get some insights.
Right. So I'll go back to Jordan and ask him a question, and Daniel and the other VCs, please help me. You ask about exit. I'm now in a situation where I have a product market fit, where I have revenue and clear clinical value, and I'm already talking to people about an M&A. I will not mention names, but that's going to be a relatively low sum, in the hundreds of millions, I would say. Or I can take a big check and go build a billion-dollar company. And for you guys as investors, how do you look at those 2 options, and what option will be more appealing to you? A short-term, relatively high probability of success versus a longer-term, bigger number, but there's always risk if you look at 3 or 5 years ahead?
I'll give you a two-sided answer. First, the number of X's depends on my model, my investment thesis. If you came in on the bottom barrel, I want you to do a few X's. If you're on the top of the barrel, I want you to do hundreds of X's. But do you have a car, Erez?
Yeah, I have a car.
Would you sell it for me?
Sure, why not? How much you're paying?
Depends on the price, right? Depends on the price. Is it 10,000? If I offer you 100,000 for 60,000, I'm sure you're going to sell it to me. So it's about the price. It's just about the value proposition at the time of the transaction. There is no hard and fast fact in terms of the exit. All I'm asking is, as you talk to investors, give us the lay of the land in your neighborhood. Who's exiting at what valuations, at what multiples? Just give us a sense of what could you become. Are you destined to be $1 billion or 300 million or 50 million? That's the bottom line for me as an investor.
Fair enough. Maybe Daniel?
That's a good response. Daniel, please.
I mean, for me, I agree with what Jordan said. I would just add something. If I'm going to place a bet on you for a longer term, sort of bigger exit, I'd like to see a little bit more focus. Meaning you've shown me the possibilities of where one could go, but I'd like to see sort of, okay, if I'm going to focus on private clinics over the next year or 2 years, here's what I'm going to do, here's what my market is going to look like, and here's the exceptional returns I'm going to deliver. Show me that. So I believe you're not just seeing the big story of what is possible. That would be my advice to you. Focus.
So probably bottoms up go-to-market plan that's what you're expecting from Erez. Okay.
Yeah. Just one thing what Jordan say and Daniela, I totally agree, but I think also I miss what is the market share you're looking for. So you're talking about your competitor, Medtronic and other. Are they purely focused on the big healthcare institute hospitals? Are they more focused on the small ones? So for me, it was still not very much clear that which market segments you want to target and what is the share you're looking for. So maybe Medtronics have a big market share of 40%, 60%, and you say, okay, I want to go for the 40%, which is still free market. So I think maybe that's something you have to focus on.
Yeah, on my side, I guess that you need to assume a scenario. I mean, for the coming 5-10 years, that what expected that the market that you are in, which is the ortho market, is becoming very aggressive in terms of pricing. The trend is that the cutting cost to be more effective because a huge cost is coming from this sector. Actually, when we talk about insurance, so assume that market pressure will force to cut the effective revenue per case for navigation by 30 to 40% in the next 5 years. So walk through your economic model that you did, the pricing model that you have, which is disposable SaaS and hardware, and see do you stay profitable on such pricing model, and from there you can have insights about your forecast and exit strategy. That's my final comment.
Thanks.
Thank you.
Thank you.
I would just add one thing, Erez. I think you talked about predictive analytics. I think at some point of the conversation, that's going to be a big driver in my view. And the second thing, I agreed with a lot of views the other panelists have given about being very focused on the canvas that you're building and as you're moving from one to other. But if I were to put it in short, I think that predictive analytics or the real-time surgical analytics and how it translates into higher streams of revenues is one thing that needs to be seen. The segments are like your hospital, you've started with ambulatory surgical centers, you're moving to the larger hospitals and all that. But in addition, I think health payers, hold a bigger sway when you look at bringing the value-based reimbursements and all that kind of stuff. So if that proposition is well established, it could open more doors. That's my point of view.
Fantastic. Thanks a lot, all the panelists. Really, really appreciate your time. And thanks a lot for giving hard time to Erez. This is what we want, right? If you give him hard time, he will think harder, learn from your feedback, improve, and definitely grow in the longer run. So that's what we want. So really appreciate your time. Erez, you have been a fantastic presenter. I mean, it requires a lot of courage to go out and present and get the feedback on a live stream in a public forum like this. And you showed that courage with a lot of confidence, clarity in your answers, and the ability to learn from the feedback from the panelists, from the subject matter experts. So really appreciate your courage, your act today, and thanks a lot for doing this today. So again, thanks everybody for joining us for this session. I hope we can reconnect and explore more synergies and help each other with different initiatives that we are running in our lives. Thank you, everybody. Thank you very much.
Thank you so
for
much.
having
It was
us.
great. Really appreciate
Thank
the
you.
questions and feedback.
Yeah.
Thank you so much.
Thank